Hello friends, welcome to the Pathology Insights, and today we will be discussing about the follicular lymphoma in this video. And before going into the topic proper of follicular lymphoma, we will have a brief about the lymphomas. Lymphoma is a tumor of the lymphocytes. It is a solid tumor of the immune cells, mainly the lymphocytes, and it will be involving the lymph nodes and lymphoreticular system. Along with that, other body parts also can be involved. And the lymphomas are mainly classified as Hodgkin's lymphoma and non-Hodgkin's lymphoma. Among both these, non-Hodgkin's lymphoma is more common. And if you remember, in the previous video, we have described about the Hodgkin's lymphoma. The characteristic cell of the Hodgkin's lymphoma is Reed-Sternberg cells. And the non-Hodgkin's lymphoma, these are again classified as B-cell lymphomas and T-cell lymphomas. Among these two, again, B-cell lymphomas are more common. And among the B-cell lymphomas, again, we have the lymphomas which have the indolent behavior. That is, they have a very slow growth and they are having some resistance to chemotherapy. Whereas there are B-cell lymphomas which have the aggressive behavior. Under that, we have diffuse large B-cell lymphoma, Burkitt's lymphoma, and precursor B lymphocytic leukemia or lymphoma. Remaining all the B-cell non-Hodgkin's lymphomas, they have an indolent course. Now, our follicular lymphoma also comes under the B-cell lymphoma having an indolent course. Now, coming to the topic proper of follicular lymphoma, this is a neoplasm which is composed of the cells which are present in the germinal center. In the germinal center, we have centroblasts and the centrocytes. So, this is a neoplasm which is composed of follicular center B cells, and these tumor cells, they will produce again the follicular pattern, because of which the name is given as a follicular lymphoma. The follicular pattern can be present throughout the lymph node, or it can be present at least partially. And as I told you, it is the commonest non-Hodgkin's lymphoma with the indolent course. Now, this is a normal lymph node where we have cortex, then we have paracortex in the medulla, and this is in the cortex we have the follicle with the germinal center, and in this germinal center we have the centroblasts and the centrocytes. So this is a lymphoma which is composed of the centroblasts and the centrocytes. Now, coming to the epidemiology, follicular lymphomas, they constitute about 20% of the lymphomas, and the incidence of the follicular lymphoma is about 3 to 4 cases per 1 lakh per annum. And this is more common in the USA and the Western Europe when compared to Asia and the Eastern Europe. And when we see the age, it involves mostly the adults and it has a slight female predominance. Coming to the pathogenesis, the most important translocation which is present in the follicular lymphoma is the translocation involving BCL2, reciprocal translocation involving BCL2 gene. So when we see the BCL2 gene, it is located on the chromosome 18. A part of this chromosome 18 along with the BCL2 is translocated to chromosome 14. So when this translocation occurs, the BCL2 gene, it comes under the transcriptional control of the immunoglobulin heavy chain, IgH locus. Now when it comes under the control of IgH locus, there is an increased expression of the BCL2. Now if you remember, BCL2 is an anti-apoptotic protein. So if BCL2 is expressed more, the cells will not have the apoptosis. Normally in the germinal center, the centroblasts will be differentiating into the centrocytes, and the centrocytes which have unfavorable mutations with low affinity antigen recognition, they will undergo apoptosis. Because they are not required, they undergo apoptosis. Whereas the centrocytes which are having which have a favorable mutations and which have a high affinity for the antigens, they survive. So in the germinal center, some of them will be undergoing apoptosis and some of them will be surviving which have the favorable mutation. So these cells which are undergoing apoptosis, they will be engulfed by the macrophages. So we have many tingible body macrophages also in the germinal center. Now in the germinal center cells, if they have this translocation and there is increased expression of the BCL2, then the centrocytes which have unfavorable translocation, they will not undergo apoptosis. Instead, they will survive and they will again proliferate. Now, for the development of the follicular lymphoma, this translocation alone is it is not sufficient to produce the lymphoma. Now, from the bone marrow, the pre-B cells will be transformed into the centroblasts. Now, these centroblasts which are formed, they already have this translocation. But as I told you, only this BCL2 translocation is not sufficient to produce the follicular lymphoma. So, the cells with this translocation, we call them as a follicular lymphoma-like cells. They behave like a precursor cells. So these follicular lymphoma-like cells, after entering into the lymph node, they populate the germinal center. And this condition where the lymph nodes have this follicular lymphoma-like cells in the germinal centers is called as in situ follicular neoplasia. Now, in this stage, we don't have lymphomas, but these follicular lymphoma-like cells we can see in the circulation and also we can see in the lymph nodes. So these cells should undergo further mutations. They should gain further mutations to form the follicular lymphomas. Now, in the germinal center, when there is a stimulation for the proliferation of the cells, so in the secondary follicles, when there is a proliferation of the centroblasts, these cells can acquire further mutations. So there can be epigenetic mutations which are affecting the histone modifying genes. So we have many histone modifying genes which undergo the mutations, but among them the important mutations are loss of function mutation of KMT2D gene. This we see in 70 to 90% of the cases, or there can be loss of function mutation of CRE gene. This we see in 60 to 70% of the cases, or there can be gain of function mutation of EGH2 gene, which we see in 12 to 25% of the cases, or there can be loss of function mutation of EP300 gene, which we see in 8 to 15% of the cases. So need not be that all these mutations should be present, but one of the mutations along with BCL2 translocation can transform these follicular lymphoma-like cells into the cells which can give rise to the follicular lymphomas. So in the germinal centers, when these cells are proliferating, they acquire further mutations, and then we have the tumor cells which gives rise to follicular lymphoma. These tumor cells, they populate the lymph nodes, along with the lymph nodes, other lymphoreticular system and the organs, or they can also disseminate through the circulation. So this is how we get the follicular lymphoma. So now, to develop the follicular lymphoma, just the reciprocal translocation of BCL2 gene is not sufficient. It is an initial step. Later, along with that translocation, we have the mutations of some other genes, among which the four important one, what I have told. These are the four most common genes which undergo the mutations. There are some other genes also, but along with the translocation and mutations of these genes, the centroblasts will develop the follicular lymphoma-like cells, and these follicular lymphoma-like cells will develop into tumor cells which gives rise to the follicular lymphoma. Now, when we see the localization, this follicular lymphoma, it mainly involves the lymph nodes, but also the other lymphoreticular system like the spleen, bone marrow, peripheral blood, and most commonly the Waldeur's ring. Extranodal involvement is Pure extranodal involvement is very uncommon, but we can have in the organs like the GIT, soft tissues, breast, and ocular adnexia. And in the GIT, the duodenal involvement, it has a distinctive feature, and it is described in the variants of the follicular lymphoma, duodenal type of the follicular lymphoma. What is the difference? We will see. The difference between the nodal and the extranodal follicular lymphoma is they are both similar in the genetics, phenotype, and the morphology. Genetics means whatever the mutations we have seen, that we can see in this also. Only thing is, these lymphomas will not have the BCL2 translocation. They lack this BCL2 protein. But the other mutations what we have seen, they will be present in these cells, and usually they are high grade 3 lymphomas. So that is the difference between nodal and the extranodal follicular lymphoma. Morphological wise, it is similar, but only thing is grade will be high, and we have the lack of BCL2 protein, because BCL2 translocation may not be present in this. Coming to the morphology, when you see grossly, the lymph node will be enlarged and it will have a nodular pattern. This nodular pattern is because of the follicles which are formed by the tumor cells. So vaguely it has a nodular pattern and an enlarged lymph node. Microscopically, when we see, we have the differences between a normal reactive lymph node and the lymphoma. How to differentiate is, when we see a normal reactive lymph node, we have the follicles which are present only in the cortex and they will be of varying sizes. Some may be small and some are large. Whereas if it is the follicular lymphoma, the follicles will be involving the entire lymph node. There is no differentiation between the cortex and the medulla. Instead, the follicles are spread all over the cortex and the medulla. And if you see, the follicles are all are of similar size. And the tumor cells, these lymphocytes which are invading the capsule and entering into the adjacent adipose tissue, they also form the nodules. So these are there are some other microscopic features. These are the important ones. The tumor cells, they form the follicles which are of uniform size and they are spread entirely in the lymph node involving cortex and the medulla. And normally when you see the follicle in a reactive in the lymph node, it will have a mantle zone. It will have a germinal center and a mantle zone, and you will have enough of the interfollicular spaces. But here when you see these follicles, they don't have a mantle zone, a specific mantle zone, and not much of the interfollicular spaces, and they are very closely packed, and we see even the cracking artifact, means like a cleft like space will be seen in between the neoplastic follicles. So these are the microscopic differences between the reactive the follicle which we see in the reactive hyperplasia and the follicles which we see in the follicular lymphoma. And in the germinal center, again, if we see the germinal center of a reactive follicle, in that we have zonation, what we call it as a polarization with the zonation. Here we have a dark zone and the light zone normally. So dark zone, it mainly comprises of the centroblasts. Centroblasts, when you see here, they will have a nucleus which is vesicular. Vesicular because the nuclear material is adherent to the membrane, so it appears as if it's empty. So you have a dark nuclear membrane and you have 2 to 3 nucleoli which are present peripherally, and they have a moderate amount of the cytoplasm. So all the centroblasts are present in the dark zone, and whereas these cells will differentiate into the centrocytes which are present in the lighter zone. So these centrocytes, they have typically cleaved nuclei and inconspicuous nucleoli in scant cytoplasm. So centroblasts in the dark zone, centrocytes in the light zone, and then these centrocytes further they will differentiate into the memory B cells or the plasma cells that comes as an apical light zone. So this is the zonation, which we call it as a polarization, and in between, as I told you, the centroblasts differentiate into the centrocytes, and the centrocytes which have unfavorable mutations with a low affinity for antigen should undergo apoptosis. So the cells which are undergoing apoptosis, they are ingested by the macrophages. So we have many tingible body macrophages in this reactive follicles, and the germinal center of the secondary follicles. Whereas when we see the follicle in the follicular lymphoma, we don't have the zonation. We see admixture of the centroblasts and the centrocytes, and we don't have any tingible body macrophages because the cells have overexpression of BCL2, so the cells doesn't undergo any apoptosis. So this is how the follicular center appears. Okay, so we don't have zonation, we don't have any tingible body macrophages in the follicles of follicular lymphoma. So this is the microscope. Okay, just brief about the differences between the follicular lymphoma and the reactive hyperplasia. In the follicular lymphoma, follicles are spread in the cortex and the medulla, whereas in the follicular hyperplasia, they are confined to the cortex. Nodules have a blurred borders and no mantle zone, whereas here nodules have sharply circumscribed and have a mantle zone. Follicles are relatively of the same size in the lymphoma, whereas they are of varying sizes. Tangible body macrophages are not seen in the follicular lymphoma, whereas tangible body macrophages are present in the hyperplasias, which give a starry sky appearance. And there is no specific arrangement of centroblasts and the centrocytes. That is, polarization is not there. Whereas here we have a polarization with the dark zone and the light zone. So these are the differences between follicular lymphoma and follicular hyperplasia in the lymph node. Now the patterns of arrangement is usually, as I told you, we have a follicular pattern, but sometimes we can have the diffuse areas also consisting of the neoplastic cells. Now when you have a diffuse areas without any nodular pattern, the patient will have the worst prognosis. So when we are giving the report, we should mention it as whether it is predominantly follicular. That means more than 75% of the lymph node is showing the follicles, or diffuse and follicular. That means 25% follicular, 25% to 75% of the follicles. Means if they are present less than 75% of the follicles till 25% of the lymph node, we call it as follicular and diffuse. Or if it is only the diffuse pattern with occasional follicles seen, that is less than 25% of the follicles, then we call it as minimally follicular. So it's important to give this in the report, whether it's predominantly follicular, follicular or diffuse, or minimally follicular, because minimally follicular type of the follicular lymphoma will have the worst prognosis. When we see the grades of the follicular lymphoma, it depends upon number of the centroblasts in the 10 neoplastic follicles. So we have to see 10 neoplastic follicles and we have to count the centroblasts. So grade 1 is if we see 0 to 5 centroblasts per hyperfields. Grade 2 is 6 to 15 centroblasts per hyperfield in 10 neoplastic follicles. Grade 3 is more than 15 centroblasts per hyperfield in 10 neoplastic follicles. And grade 3 is again classified as 3A and 3B. 3A means you have more than 15 centroblasts, but centrocytes are still present, whereas 3B is you have only the centroblasts with no centrocytes. So this is how the grading is given. Now coming to the immunohistochemistry, follicular lymphoma cells, they express all the B cell markers like CD19, 20, 22 and CD79A, and they are negative for the T cell markers CD3, CD5 or CD23. But the thing is, when we do the IHC, sometimes we get positive CD3 positive cells because they are the T cells which are interspersed in between the these tumor cells. And tumor cells are specifically positive for CD10. So CD10 positive cells will be seen in the nodules and scattered outside the nodules. BCL2 protein usually positive in the nodules, and this is more in the grade 1 type of the tumors, whereas in the grade 2 and grade 3 expression of BCL2 is reduced. And BCL6 positive cells we see in more than 85% of the cells in follicular lymphoma. So the important markers to identify is CD10, BCL2 and BCL6. And in this the proliferation index is low, Ki67 is low, and even we can see the follicular dendritic meshwork, how it is. If we have to differentiate between whether it's a reactive follicle or a follicle of the follicular lymphoma, when we do the markers like CD21 and 35, which are for the dendritic cells, we see a widespread meshwork in the lymphoma, whereas in the reactive follicular hyperplasia, they are confined to the follicles and they will be present within a similar diameter. And even the cells are positive for monoclonal kappa and the lambda, and also for the surface immunoglobulin IgM and the IgG. So here the important IHC markers are CD10, BCL2, BCL6, and if we want to see the dendritic cell distribution, then we have to do the CD21 and CD35. Now coming to the staging of the follicular lymphoma, it depends upon how many number of the lymph nodal areas are involved. If it is a single lymph nodal area, then it comes as a stage 1. If it has multiple lymph nodal areas which is on one side of the diaphragm, then it is stage 2. If you have multiple lymph nodal areas involved on both sides of the diaphragm, it is stage 3. And then if these tumor cells are involving along with the lymph nodal areas, the organs also, then it becomes as a stage 4. So as the stage increases, the prognosis is worse. Now this follicular lymphoma, it can further progress and transform into high-grade diffuse large B-cell lymphomas, or it can transform into immunoblastic lymphomas or diffuse mixed lymphomas and the Burkitt lymphomas. Means these indolent follicular lymphoma which have an indolent course, they can slowly transform into the lymphomas which have an aggressive course. Now, poor prognosis in the follicular lymphoma is found to be associated with the late stage of the disease, older age group, if the bone marrow is involved, and if the patient has systemic B-type symptoms like fever, night sweats, and the weight loss, and if there are the high levels of lactate dehydrogenase, and if there are high beta-2 microglobulin levels. So these all are indicators of the poor prognosis. Now we have a prognostic index also, what we call it as a Follicular Lymphoma International Prognostic Index, which is useful in predicting the outcome. So they have given certain indicators, 5 independent indicators to calculate the inferior survival. So each one carries one score. So we have 5 indicators: age more than 60 years, hemoglobin concentration less than 12 grams per deciliter, elevated serum lactate dehydrogenase, and an Arbor stage of 3 or 4, and if there are more than 4 involved nodal areas. So we have to calculate the score by adding this independent indicators. If we have the presence of only 0 to 1 of these adverse factors, then they are low risk. And if we have presence of 2 of these adverse factors, then it is independent risk. If we have 3 to 5 of these adverse factors, then it is a high risk disease. So this risk assessment is given by the Follicular Lymphoma International Prognostic Index. Now there are variants of the follicular lymphoma which I am not going to discuss in this video, but just I am mentioning what are the variants. We have in situ follicular neoplasia, duodenal type of follicular lymphoma, testicular follicular lymphoma, diffuse variant of follicular lymphoma, and primary cutaneous follicular lymphoma. Just know the variants, we will discuss about them in other video. Now this is as a whole summary. So if you remember, definition is, this is a neoplasm which is composed of the cells of follicular center B cells. They constitute about 20% of the lymphomas and more common in the females in elderly age group. And when we see the pathogenesis, the B cells which have this BCL2 translocations, they are called as follicular lymphoma-like cells, which are the precursors. And these follicular lymphoma-like cells in the germinal centers, while proliferating, they further acquire the mutations. And these mutations, when they acquire, they transform into the tumor cells, giving rise to follicular lymphoma. And in that, the genes which are involved are KMT2D, which is most commonly involved. Another one is next important is CRE-BBP gene, and EZH2 gene, and EP300 gene. As I told you, there are other genes also which can be involved, but these are most commonly involved genes which undergo the mutations in these cells. Then sites, when we see follicular lymphoma, most commonly involves the lymph nodes and lymphoreticular system. The extranodal involvement is very uncommon in this. And grossly, when we see, we have the lymph nodes which are enlarged and they have a nodular cut surface. Microscopy, when we see, as I told you, we have the follicles which will be involving the entire lymph node, that is involving the cortex and the completely the cortex and the medulla, and the cells will be like a germinal center like cells, have centroblasts and centrocytes, and the follicles will be closely packed with less interfollicular area. They will be of uniform size and shape, and there will not be any mantle zone, and cracking artifact can be seen. And if we see specifically, we'll see the germinal center in the high power. There will not be any polarization, there will not be any zonation in the follicular lymphoma, and there will not be any tingible body macrophages. And when we see the grading, it is graded depending upon number of the centroblasts. If the centroblasts is 0 to 5 per hyper field in 10 neoplastic follicles, it is grade 1. 6 to 15 centroblasts per hyper field in 10 neoplastic follicles, it is grade 2, and grade 3 is more than 15 centroblasts per hyper field in 10 neoplastic follicles. Then again, if the centroblasts and centrocytes are also seen, we call it as 3A. But if only the centroblasts populate, then we call it as a 3B. And we have the 4 stages of the follicular lymphoma, where stage 1 is involvement of single nodular area, single lymph nodal area. More than one lymph nodal area on one side of the diaphragm is 2. And more than involvement of one lymph nodal area on both sides of the diaphragm is 3. And if it involves the organs also, it comes to stage 4. And further, these follicular lymphoma cells, they transform into aggressive lymphomas. Then indicators has been given for the inferior survival, that is by the Follicular Lymphoma-International Prognostic Index, which takes 5 indicators: age more than 60 years, hemoglobin less than 12 grams per deciliter, elevated serum lactate dehydrogenase level, and the staging of 3 or 4. And we have if more than 4 lymph nodal areas are involved. If a single indicator is present, then you have a low risk inferior survival, there is a low risk. Intermediate risk is present if you have 2 or more of this, presence of 2 of these adverse factors. If it is 3 or 5 of these adverse factors, it is a high risk disease. So that finishes about the follicular lymphoma. Thank you, friends. Thank you for listening patiently.